Okay, so Anesthesia also created a handout that's specific for anesthesia. So you would have a little bit more information that you can print off, you can keep, you can use in the future, however it helps you. So three primary types of anesthesia is the general, regional, monitored anesthesia care, or MAC. And it gives you some examples of what those particular things are. Note here is local anesthetic is not reported using anesthesia codes. Local anesthesia is included in the surgical package and do not report separately. All right, the terminology you're going to be looking for is you've got a one lung ventilation, pump oxygenator, intraperitoneal, extraperitoneal, retroperitoneal, radical diagnostic surgical arthroscopic procedure, and coders assign a diagnostic code only if no surgical procedure is performed, such as if a knee arthroscopy is listed as a diagnostic and meninectomy is performed, surgical arthroscopy code is assigned, meaning you pick the most comprehensive anesthetic code to assign to both. You only assign one. CPT coding. Services included, meaning we don't code these. That's why there's a line through them. All usual preoperative and postoperative visits, anesthesia care during the procedure, administration of fluids and or blood, products during surgery, non-invasive monitoring, such as ECG, temperature, blood pressure, pulse ox, capnography, and mass spectrometry. Services not included, meaning that you can assign these separately, is unusual forms of monitoring, for example, arterial lines, central venous catheters, and pulmonary artery catheters, such as Swan GANs, and these are coded separately. To calculate time, it begins when the anesthesiologist begins to prepare the patient for anesthesia in either the operating room or an equivalent area. And pre-anesthesia assessment time is not part of the reportable time. It ends when the anesthesiologist is no longer in personal attendance and generally is reported when the patient is safely placed under post-operative supervision. Note here, time does not need to be continuous. For example, an axillary block may be performed in the holding room prior to surgery. If the axillary block is the mode of anesthesia, then the time for placement of that block is counted. The anesthesiologist may then leave, and when the patient is brought to the operating room, and the anesthesiologist again begins to count that time. So you add that time. So if it's 5 minutes, you add that 5 minutes to the rest of the time. Medicare. For Medicare, it requires exact time reporting. So if anesthesia starts at 11:02 and the patient is turned over to the PACU at 11:59, the reported anesthesia time is 57 minutes. Medicare divides 57 by 15-minute increments for a total value of 3.8. The procedure has a base value of 6, adding 3.8 units give a total of 9.8 units, which is then multiplied by the anesthesia conversion factor for the geographic location. Other insurance carriers, they can process in increments from exact time like Medicare to 10, 12, or 15. I've only done 15 increments, but there could be certain carriers that do allow different increments, so you need to make sure you're aware of the carrier specifics. Surgical time does not play a role in determining anesthesia time. Multiple surgical procedures. Again, if we have one patient receives multiple anesthesia for multiple procedures, You're going to select the most complex procedure is recorded because this service carries a higher base unit value, and the anesthesia time is reported as usual. So from the time they begin to prep the patient to the time they are placed in post-operative supervision. So the example here, a patient has an inguinal hernia repair, 00830, base unit of 4, and a ventral hernia repair, 00832, the base value unit is 6. Only the ventral herniorrhaphy, 00832, is reported because it is more complex and the base unit is higher. We only use the secondary procedure for the time allowed for anesthesia. Our physical status modifiers, again, you want to make sure that you have this in your CPT book because this is not always given during a certification exam. So although you do not need this particular units for the physical status modifiers on the certified medical coding specialist exam, you do for AAPC to do calculations. So P1 is a normal patient. It has a 0 unit for that modifier. P2, mild systemic disease, again 0. P3, you're going to add 1 for severe systemic disease. P4, you're going to add 2 when it's a threat to life. 5, moribund, it's the patient's not expected to survive. You're going to add 0.3. P6, the patient is brain dead and they're just simply doing it for organ donations. It's a 0. So the example, a non-Medicare patient has a severe systemic disease, which is a constant threat to life and is undergoing a direct coronary artery bypass graft, a CABG, with a pump oxygenator, is reported as 00567 P4. So these are placed on the anesthesia code. Qualifying circumstances. So these are the additional things that tells us a little bit more information about the patient, and they are listed in the anesthesia guidelines. So they are add-on anesthesia codes assigned to report anesthesia services performed under difficult circumstances affecting significantly the character of anesthesia service. So they are not listed in the CPT. They are listed at the beginning of the anesthesia code. So 99-100 is extreme age. So they're either younger than 1 or older than 70. And then it also carries a unit of 1. 99-116 is complicated by hypothermia. It's a positive 5. 99-135 is complicated by controlled hypotension, positive 5. And then 99-140 is complicated by emergency condition, and it will be specified, and it's a positive 2. So the note, highlight parenthetical notes pertaining to the use of qualifying circumstances codes with the CPT, the anesthesia. So for example, 00326, it states do not report 00326 in conjunction with 99-100. So you want to make sure that you pay close attention to those notes. You've probably seen some examples in Cengage's homework on AAPC. That will be a certification type test, but for your certified medical coding specialist, you're not going to have this question. Additional billable items by the anesthesiologist. So you have invasive monitoring devices. You can assign an additional code. If another provider, such as a surgeon or a perfusionist, places the line or catheter, no additional information is reported by the anesthesia provider. And then the anesthesiologist only reports services that he or she performs. Time is not reported separately for flat fee procedures. So these are found in the surgery section, and no time is associated for reporting payments. The most common codes reported in addition to anesthesia services are 31,500 for intubation, Emergency intubation is reported separately when patient is not undergoing anesthesia. Normal intubation undergoing anesthesia is included in the anesthesia code. 36620 is an arterial catheterization or cannulization for sampling, monitoring, or transfusion, and it's percutaneous. It's placed in the radial artery through a needle puncture of the skin. 36,555 or 36,556 is an insertion of a non-tunneled central venous catheter. It is age related, so you're going to pick it based on the age. And then 93,503 is insertion and placement of a flow-directed catheter, such as Swan-Ganz, and they could simply call it a Swan-Ganz is placed, SG, for monitoring purposes. So the example here we have anesthesia code. Coder looks for documentation to support placement of a pulmonary artery catheter by the anesthesia provider. It is identified as either a PAC, pulmonary artery cath, or an SG, Swan-Ganz, and should have a procedure note documented in either the comment section of the anesthesia record, in the progress notes, or a separate procedure form. Then moderate sedation versus the monitored anesthesia care. So moderate sedation is provided by a physician other than the surgeon. Anesthesiologists may administer, provided without anesthesia machine or backup for general anesthetic. Moderate sedation does not include minimal sedation, deep sedation, or MAC. And only anesthesia providers report anesthesia codes again. Monitored anesthesia care is distinctly different than moderate sedation. It involves the administration of the sedatives, analgesics, hypnotics, anesthetic static agents, and other medication necessary for patient safety. Patient does not lose consciousness, is arousable, and is able to maintain open airway. Provider must be qualified and prepared at all times to convert to general anesthesia as needed. The modifiers you're going to see with this is 23, 47, 53, 59, 73, and 74. Examples of correct modifier appendage is we have 00910, which is the anesthetic code. AA is who administered the anesthetic, and P3 is the physical status modifier. So to report a personally performed physician service with physical status 3 patient. 00142 again is the anesthetic. QK, QS, P3, and 00142 QX, QS, P3. And this is to report the medically directing physician and CRNA service with a physician status 3 patient under monitored anesthetic care. So it's the same anesthetic, but you have one reporting for the directing physician and the second reporting for the CRNA. Most anesthesia modifiers are reported only with anesthesia codes, and they are not listed with other CPT code categories. Okay, that gives you a little bit of background on this anesthesia form. It not only helps you answer the few questions you have on the anesthesia chapter with the CMCS, but if you go on to take the AAPC certification, or you're going to utilize it later, then you may utilize this particular tool.